All right, welcome today to our EKG series. I'm John Felt. I'm joined today by Dor Markush, pediatric cardiologist. We're going to be talking today about the basics of EKGs. So Dor will start off just, very briefly and very basically, what is an EKG?
Thank you guys for having me today. It's a pleasure. The EKG essentially is used to analyze the electrical system or electrical properties and conduction of the heart, which the heart uses a mechanical component to pump blood, etc. But it also drives based on its own intrinsic electrical system, and so that's what the EKG analyzes.
Okay, so most of the time we rely on our nursing staff or our techs to be able to place the leads correctly to get the EKG that we then interpret. But really understanding where those leads go is critical to understanding how to interpret the EKG. So today let's talk about how do we place these leads, where are they, and really what is that then, how does that translate to this printout that we see, this essentially 2D representation of a three-dimensional structure.
Yes, and I think that's a very good point, because I think that before you begin to analyze both normal and abnormal EKGs, it's very important to understand what the EKG means and represents. And the leads have to be placed properly in order to create the right way of looking at the electrical system, especially from the vectorial approach, which includes both magnitude and direction. And so if the leads are not placed properly, that can turn a completely normal EKG into an abnormal one, and vice versa. The electrical conduction of the heart is actually seen in a three-dimensional plane, but there are two main dimensions that we look at with the EKG leads. There's the first one is what we call the limb leads, which are shown here. This also is made up of 4 different points where the leads are placed, and this also ends up creating the Hicks axial system. And so here you see that there's a sticker with a lead placed on the right arm, the left arm, the right leg, and the left leg. This could be placed either at the shoulders and at the waist area, or it could even be placed more distally, at the hands or the feet. We tend to place them more centrally just to decrease motion artifact, but essentially you would get the same results. But this creates what we call a Hicks axial system, and as the name implies, it's really 6 different vectors that you see here. There's the 2 main kind of bifurcating vectors that cross at 90 degrees to each other. The first is lead 1. And the second one is lead AVF. Lead 1 goes straight across, and AVF goes up and down. Now, it's important to explain that the Hicks axial system, as I mentioned, we analyze the electrical conduction in really a three-dimensional way. But this first set of leads, the Hicks axial system, or the limb leads, analyzes the electrical movement, as you can see in the picture, both in the superior-inferior axis as well as the right or left axis. So you see here that 1 goes straight across, is a horizontal lead, and AVF is a superior-inferior lead. You also see that there's directionality. So where the 1 is shown here to the patient's left is the positive portion of that vector, and the opposite end would be the negative.
So on the left, or on
so
the right.
To the patient's right would be negative. AVF, as you point towards the patient's inferior portion, that it will give you a positive change in AVF, and superior would be negative in the same lead. The other 4 leads are lead 2 down here, which is pointing toward the patient's left foot, and lead 3. These will both be positive, pointing to these respective directions, and would be negative. These leads aren't shown to continue here, but for example, in lead 2, this would be the negative part of it, and in lead 3, this would be the negative direction of that. Lead AVL and AVF are over here, so superior and to the right would be AVR, which would show you positive. It's always positive toward this end of the vector, and would be negative going away from the vector this way. AVL would be positive in this direction toward the left arm, and negative in this direction, bottom and to the right. So this is the main hex axial system, which again is 6 bidirectional vectors that both have a positive and a negative end, and these represent the limb leads.
And really, this is no different than what adult ER residents are learning and interpreting on their patients as well, right?
Exactly the same. In terms of the mechanism of analyzing the EKG using a vectorial approach and the setup, this is exactly the same in children and adults.
And the only thing that you mentioned is that like placing the leads maybe more proximal or centrally toward the body will help to eliminate a little bit of artifact.
Correct.
Okay.
Which would especially be important in a young, baby that's kicking legs and stuff like that. So.
Correct. But if they're squirming around, you may even get some artifact with the leads placed this
Obviously.
way. But yes, it does help to some extent. Now, the other portion of the EKG, and Jen, you brought up a good point because this does change. This is a little bit different in peds compared to adults, as we'll see just in terms of having a couple of extra points here. But again, the concept is the same. So the other portion of the EKG and lead placement are these chest leads. And these are also known as the precordial leads. And the precordial leads, as you see, again, are placed at the surface of the heart. And these are the location. V1 is placed just to the right of the sternum at about the 4th intercostal space, and that's over here. V2 is placed kind of a mirror image to that, so 4th intercostal space just to the left of the sternum. And V4 is placed kind of in the mid-clavicular line, going down here, in the 5th intercostal space. V4, V5, and V6 are essentially placed, at about the same level in terms of the 5th intercostal space, but they gradually go more lateral. So V5 is approximately the anterior axillary line, and V6 is the mid-axillary line. In pediatrics, so the combination of this plus the limb leads that we've spoken about would give you a 12-lead EKG, and we'll see why. But in pediatrics, very often, because kids have more of an RV dominance, and the right side, is looked at more importantly because of its relevance compared to the adults, we also add a couple more leads. So usually there is a lead V3R right over here between what says V1 and V4R. And V3R and V4R are these two right-sided leads, again, to better analyze the right side in kids. And they're essentially mirror images of V3 and V4, but on the right side. And then there's another lead called V7, which is just placed just more distal or just after the V6.
On the back.
Yeah. Now, if you combine both the limb leads and the precordial leads, you essentially get these different axes. As I mentioned, the limb leads analyze the heart in the superior, inferior, and right to left axis. And the precordial leads really, as you can see in this diagram to the right of the screen, analyzes the heart in the anterior, posterior, and left and right axes. So this is the spine or posterior here. This would be anterior, the anterior portion of the chest or sternum. And this would be the patient's left, and this would be the patient's right. So you can see here that while this, while the limb leads look at the heart in the up and down and left and right, this looks anterior, posterior, as well as left and right. And you can see here that going toward the sticker or where the lead is placed is always a positive direction or positive inflection on that lead, and then the opposite of that vector is negative, and that's shown here. The sternum would be roughly about there, and so you can see the V1 is placed just to the right of the sternum, V2 just to the left, V3 to V6 goes progressively laterally. And when you superimpose these two things, and you put them all together in somewhat of a three-dimensional view, you get this. So this is actually, and it's important to know that the EKG actually really looks at the heart, again, from these different angles. And so this is the heart in a person's chest, and you can see both the limb leads in this light blue color, and that's looking at the heart. It's hard to tell here in 3 dimensions, but that's looking at the heart, in the anterior superior, in the inferior superior and right and left standpoint. And the precordial leads here in the dark blue look at the heart from the anterior posterior and right and left standpoint. And that essentially, makes up the 12 or in pediatrics 15 lead EKG. So when you look here at an example of a normal EKG, the electrical activity looks different in each lead, and that's because we're really looking at the same overall electrical activity of the heart, but again from a different viewpoint. So you're looking at the same thing, but just from different viewpoints, and that's giving you different deflections based on that curve. The general trend here is that most of the inflections are in the positive direction. Both the P wave, the QRS, and the T wave are in the positive direction. Lead 2 is to the bottom left, and the general progression of the electrical activity is from the SA node, the sinoatrial node, up here, down to the AV node, and then down in this portion to both the left and right. But in general, the progression is from the right upper area to the left lower quadrant, and that's why lead 2 is generally always a positive lead.
So, a lot of times when we're looking at the EKG, when we're comparing adults versus children, the stickers that these leads or the wires are attached to are pretty large in adults. So we cut them down. And really it seems like the only reason for that is just, we need contact to the skin. And in a baby, it's, a very small surface area. So cutting the stickers in half doesn't really change anything with that electrical conduction or the pickup of the electrical activity, does it?
Yeah, it's a good question and an important question because, as you mentioned, a lot of times in kids and sometimes in neonates even, there just isn't enough room to place the stickers in the proper location, if we're using adult stickers.
Especially if we're going to 15 different stickers on there.
Right. So, the answer is that it doesn't change anything if you cut the stickers, as long as there's still good contact between whatever is picking up the electrical activity and the skin.
All right, thank you. That's very helpful. So again, a quick summary as we see, in the pediatric EKG, it doesn't really matter how distal or proximal the leads are, but if they're more proximal, you may remove a little bit more artifact. But we are looking at, the limb leads, which are 1, 2, 3, and AVEF, AVL, and AVR are those that help us to understand superior, inferior, right, left axes, and then the limb leads as they are placed, starting on the right side of the sternum and wrapping around to the back of the patient, give us that anterior, posterior, right, and left. So appreciate your time today, Dor, and for this great introduction to the very basics of EKGs.
My pleasure.